Welcome to the Be Fit Blueprint Podcast. We are your hosts, Cody Israel and Brad Durham. For all you Be Fit members and beyond, this is where we break down the blueprint of building a healthier, stronger you. In every episode, we share actionable tips, expert advice, and real stories to inspire you to level up your mind, body, and lifestyle. Whether you are just taking your first step or pushing for the next breakthrough, we've got the tools to get you there.
What is up, Be Fit? Welcome back to the Be Fit Blueprint. This is episode 10. All right, this will come out in the first week of October. We have a special guest with us, Dr. Lindsay Rice. We today are going to cover a topic that we don't think is covered often enough. All right, and that is going to be hormone replacement therapy, specifically talking to women for the most part. We find this relevant because here at Be Fit, the majority of our members, over 50%, maybe closer to 60%, are women. All right, so at some point in their life, this is an inevitable road that they are going to cross. All right, and so this is a way to, as they go through menopause, a way to help with that. So, Lindsay, I'll let you introduce yourself and talk about what you have got, and then we'll start the conversation.
Okay, perfect. As Cody said, I'm Lindsay Rice. I'm a board-certified family medicine provider. I work for Mosaic, and I have been practicing now for 13 years, I think. I went to the University of Missouri for medical school, and then I was up in Nebraska for residency. My family moved down here. It'll be 9 years ago in October, and I started here at BFit, I think 7 years ago, maybe.
Yeah, 2018, 2019, somewhere in there.
So, yeah.
And then you started personal training with me probably 4 or 5 years ago.
5 years ago,
Yep.
when I was right before I turned 39.
Yep. Rock Chalk Jayhawk, by the way.
Go big.
Forgot to throw that out there. All right, so we're going to start off the conversation just as a kind of define what is perimenopause, menopause, postmenopause.
Sure. Okay, so this is important because all of us that are women will have some sort of experience with this one way or it's inevitable, as Cody said. Premenopause is before a certain day in time. Postmenopause is after a certain day in time. Menopause is simply defined as one day in time when it has been 365 days since your last period.
Mm-hmm.
But what about women that had a hysterectomy in their 30s or 40s or 50s? How do they, there's no defined time for her.
Mm-hmm.
Perimenopause is this really fun, chaotic up to 10 years before a woman goes through menopause. I don't know when that day is going to be for me, so I'm just guessing that probably that's where we're at.
Shots in the dark.
Yep. Postmenopause is any time after whatever that day is, forever. And it is brought on by a rapid decline in estrogen production. And a ceasing of ovulation. Women are born with all the eggs we're ever going to have, and eventually those run out. And so that's how that all comes about. Is
there certain things, and Cailie, feel free to chime in here. I totally forgot to introduce you. We have Cailie, our nutrition coach, on with us because this is also relevant with her. Is there things that cause that obviously it's going to be inevitable that all of that is going to happen, but is there certain things you can do to prolong that from happening or keep it from happening sooner? Or is it like a average for everybody? Like it's going to happen in this time frame?
Short answer is there really isn't anything you can do personally to prolong the time until you go through menopause because you have no way of knowing when that is. It's not a possum. But there are lots of things you can do to make those transition years and those years post better if you have problems.
And so what are some symptoms that one might be like starting to go through this?
Sure. So perimenopausal symptoms are very vast and varied, just like postmenopausal symptoms are very vast and varied. I usually tell patients that women, we are not complicated, but we are certainly complex. But premenopausal women, declining energy.
Cody disagrees.
Yeah.
I was going to be like, ain't that the truth?
Yeah. Complex, not complicated. Declining energy, hot flashes, mood swings, muscle aches and pains. My postmenopausal ladies are having a lot of increased joint pains. Frozen shoulder is a symptom. Itchy ears is a symptom. Pain with intercourse, decreased libido, weight gain, particularly around the midsection. That's a big one.
Now, that's one that I've noticed, especially with a lot of, not a lot, but with personal training clients, women that are in their late 40s, late 30s, going into their 40s, I've heard multiple times, like, I'm doing the same things. My body's just storing body fat differently. I'm starting to gain weight. I'm not getting any stronger, all of these things. And for the longest time, for me, it's like, oh, you're not consuming the right foods. Right. You're not consuming the right amount of foods. You're not doing this and that. And so I apologize for any clients that I told that in the past, before I really understood the effect and the effects that like the hormones play in the role of perimenopause and menopause.
Yeah. Is it true that the lack of estrogen makes it changes the way we store fat in our body?
Yes.
So lack of estrogen causes more like a man's body composition.
Well, you get that increased visceral fat starts to happen around that
and
time.
decreased around the hips and thighs.
Yes. Yes, very much so.
Yeah.
Okay. So we kind of have the symptoms. So I guess explain what hormone replacement therapy is then.
It depends.
Okay. Well, let's hear all of it.
There are lots of different ways to do hormone replacement therapy. Hormone replacement therapy, which I really like to call just hormone therapy, is really just finding out what a particular woman needs, because we are not the same, and adding some supplementation of whatever hormone seems to be what she needs. Sometimes it's 3 hormones, sometimes it's 1 hormone, sometimes it's 2 hormones, coupled with all the other things. You still have to do all the other things. This is just a tool that makes those things easier.
So you still want to work out, you still want to eat whole foods, you still want to be active, you still want to sleep. This is kind of like what we talked about on the last podcast, not the exact same as a supplement, but filling in the gaps for where you can lacking that can really boost up how you're feeling.
Your sleep in perimenopause or menopause is awful.
And I might argue that all the things that we've been teaching, protein, steps, water, all those things become even more important during this time. So for me personally, I had to dial in on basically everything, all the things, even more so than I was. So like lower sugar, better hydration, really doing everything I could to get better sleep. Really, really locked in makes a big difference.
Okay. And so I guess I would assume you do you would have the person do a blood panel test and kind of see where the hormone levels are?
Yes and no. So we can do some labs and we can look at what those hormone levels are. But in perimenopause, today your estrogen might be great. 3 days from now, it might be in the gutter. It's just this chaotic thing. We can see trends, however, in the lab work that's really helpful. We can check testosterone, see where that's at, see if that's a possible contributor to what we're dealing with. And so I use labs, again, as a tool, but I try very hard to talk to women about their symptoms first, labs second.
And so, based on the symptoms, you kind of have an idea on what hormone or hormones that they might need?
Based on the symptoms and just kind of where she's at. So if we are very much in perimenopause and our symptoms are limited to these kinds of things and our estrogen level looks like it's okay when we do the labs, I will start probably with some testosterone conversation, which is a long conversation because getting women testosterone in this country is very difficult to do.
Yeah.
But if I have a woman that comes in that's 2 years postmenopausal, she's still miserable, she didn't know this was an option for her, I will, check labs, although again, the labs are just a tool.
Yeah.
But I know I will probably start with estrogen for her.
Okay. And so what are the hormones that make up, hormone replacement therapy?
Yeah.
So you mentioned a couple there.
Yeah, testosterone. Interestingly enough, our bodies make 4 times the testosterone that we make estrogen, we just kind of ignore it. Estrogen and progesterone. Progesterone is given for 2 main reasons. If you still have a uterus and you are doing estrogen, you have to do progesterone because unopposed estrogen over years and years and years, not months, over years and years and years, can increase the thickness of the uterine lining and potentially lead to uterine cancer. I am not in the business of giving people cancer.
Yeah.
And so we use that. The other reason I will use progesterone, say a woman doesn't have a uterus anymore, but she's still struggling with anxiety or trouble sleeping at night, progesterone is a lovely little hormone to help with those symptoms.
Progesterone was the first thing that I started with.
Yeah.
And it really helped with sleep. Like significantly,
you want to take
and anxiety.
It like right before bed because in about 10-15 minutes, lights out.
Yeah.
Okay.
Yeah, it's like GABA response.
It's the GABA receptors.
Okay.
Yeah.
The BeFit Blueprint is brought to you by Bratton Dental Company, where your smile is our priority. At Bratton Dental, we combine state-of-the-art technology with personalized care to give you the confidence you deserve. From routine cleanings to advanced cosmetic and restorative treatments, our expert team is here to help every step of the way. Ready to love your smile? Visit BrattonDentalCo.com today and schedule your appointment. Bratton Dental Company, bringing life to your smile.
So then the role, okay, so that's progesterone. What are the roles of like the other two? Like in those cases, what would you use those for?
Sure. So when we're doing, say, postmenopausal woman, we will start with either estrogen or progesterone based on where she's at. The estrogen is going to help with a lot of the symptoms such as hot flashes, fatigue, brain fog, irritability. The dosage is also very important because everybody is afraid of estrogen. And we can talk about why they don't have to be. But the dosage is very important because what we are using is merely a fraction of what your body used to produce. I also use mainly what they refer to as bioidentical hormones. Bioidentical is just a marketing gimmick. But what it means is my body makes estradiol.
Yeah.
I use estradiol to replace that.
Okay.
Yeah.
And then...
testosterone. So testosterone can help a lot with energy, and that's a really big one. Brain fog, irritability, and then of course libido. But I usually pitch that to women as the last part of our conversation because I do not feel that our libido has to define our ability whether or not we're going to be treated for other problems.
Yeah. Okay. So we've identified the three hormones. So let's talk about, before we go too far, like because you were talking about kind of, I don't want to say the pushback, but kind of misconceptions around especially testosterone and estrogen.
Sure. So I went to medical school right after this enormous women's health study came out. The WHI, the Women's Health Initiative, started in the early 90s, and it was actually supposed to find out the effects of hormones for women for cardiovascular disease, bone health, and strokes, I think, was the other one. And they did it with 2 separate arms. They enrolled over 160,000 women. But here's the irony to this. This was the first time they had ever done a study about women's health that was remotely this size. And this was in the 90s and 2000s.
25, 30 years ago?
Yes. Research studies even today are still less than 30% women.
Yeah.
So that's a whole nother frustrating thing. But so they did this huge study, and they ended up stopping one arm of the study that involved conjugated equine estrogen, which was the estrogen type that they used. We call it CEE, and a progestin combination. And because they stopped this study and they came out, and for the first time, which not how medical studies are ever disseminated, they came out and had a press conference.
Oh, wow.
And that week,
I remember it, actually.
That week, the front page of Newsweek or Time was the truth about hormones. And they came out and said, hormone replacement therapy causes breast cancer. Full stop.
And that was it.
That was it. And overnight, millions of women were yanked off their hormone therapy, either because their doctors were terrified, or they were.
Yeah.
But like our grandmothers and our great-grandmothers, they all took hormone therapy. That was just expected.
So like a whole generation got halfway treated or not treated at all.
Well, my mother, I was in med school when right after this came out. My mom was 50 when I was in med school. And she called me and she said, well, what do I do about this?
Yeah.
Because I was the medical person. I said, no, Mama, you shouldn't do this.
Yeah.
And
at the time, you didn't know any.
I didn't know anything. That's what we were told. That's what we were taught. But in hindsight, they've gone back and kind of re-looked at the data. And when we went back and re-looked at the data and you kind of looked all the way through it, the other arm that was just the equine estrogen, those women, they kept that side of the study going. Those women had a decreased risk of breast cancer. They had a decreased risk of heart disease, decreased risk of stroke, all of these things in the right aged woman.
Yeah.
And that's the other part. If you are more than 10 years out from hormones, then hormone replacement is probably not the safest option for you.
So the timing is important.
The timing is important. And everything I do in my job is about risk versus benefit. Everything we do every day is about risk versus benefit.
Absolutely.
Getting in the car, putting on my seatbelt, drinking my coffee. Am I going to have this glass of wine tonight? All of those things are about risk versus benefit.
So, okay, going back to the age thing. So what if someone, so obviously if you start too old, quote unquote, too old, then it is, the risk is probably more than the reward.
Right.
So if you start at
from a cardiovascular standpoint.
Okay, from a cardiovascular standpoint. So if you start at the right age and then continue on and you get to that age, then do you just continue on?
They will bring me my hormones in the nursing home.
Okay.
If I end up in the nursing home, because I'm trying really hard not to.
Okay, that's what I was wondering. So it matters if you start it, then you continue on. But if you miss that window, then you're probably not advised to start it from a cardiovascular standpoint.
I probably wouldn't start estrogen therapy in a woman that's 70 years old.
Okay.
I just don't think that would be helpful. But the other key part of this is when they've gone back and re-looked at the data, there's no evidence that breast cancer is caused by estrogen.
Okay.
This is it's controversial because we're brought up from a very young age to be terrified of breast cancer.
Yeah.
Yes.
Terrified. Like that's what we're afraid we're going to die from. But when they went back and they looked at the data, there is no increased risk, and you actually have a better chance of surviving breast cancer if you had been on HRT.
Well, it's protective benefits.
It's protective benefits.
Yeah.
But estrogen can't cause it.
Yeah.
It can feed it. So that's why regular screenings are still important. If we were to find something, I would stop your estrogen right away, but it would not.
It's not going to directly
cause
it.
Self breast exams are really important.
You got to pay attention.
Yeah.
Okay.
Yeah.
Well, that's good to know. Okay, so that covered most of the estrogen. So to the testosterone.
Sure. So I'm in this premenopausal funness. It's awesome. And what I find with a lot of women my age is that we are all very tired. We are exhausted. We have busy careers. We have houses, husbands, children. We're chasing kids around all the sports that, your kids did.
Taking care of aging parents.
Taking care of aging parents, all of the things. And we are tired. And we can't think clearly. And yet we still do it all.
Yeah.
You still get it all done.
Just push through.
But you trudge.
Yeah.
And so in that setting, and in the setting that you do have some lower testosterone levels, it is a way to provide additional help and energy in that part. The other major benefit to testosterone therapy is libido. I have women that come to me and say, I love my husband, but when he reaches out to touch me, I leave the room. And this is just you replace this and that will help. It doesn't fix relationship problems.
Yeah.
But it can make you feel more like you. And if you feel more like you, then, it's easier.
Everybody wins.
Everybody wins.
I think my experience with perimenopause would be like, I would almost have to do an energy assessment of what I could do. So if I could work out, then cleaning the house was off the table. Whereas before I could do all of it. I could work out, work, clean the house, make dinner, go for a walk. I found that I was having to pick and choose what I did for the day because based on my energy level.
And then you would dread going to sleep at night because you knew your sleep was going to be so horrible.
Yes, I would have sleep anxiety.
Yeah.
100%. Yeah.
All right. So basically, because I don't want to freak. So because I'm not a female, I'm not going to experience this.
But you will have direct contact.
Yes, this is true.
Direct contact with multiple women in multiple age ranges.
Yes.
Probably bombarded.
Yeah.
Your mom, your wife, your daughters,
So I'm just trying. So even without testosterone and being on the others, like your sleep is still going to be affected, right? From what it
certainly can be.
Okay.
Yeah.
Because I'm just trying to think like being as like well-rounded as you can, like trying to get your sleep, trying to eat whole foods, trying to do all this stuff, it can still be affected because your hormones are tanked.
Even if you're doing all the things.
Okay.
Good sleep hygiene, all of it.
The things.
Yes, same.
And it was, I dreaded going to bed.
Same.
Okay.
Yeah.
Huh.
Yeah.
That's real interesting.
Yeah.
That sound,
and I don't
not
know,
envious of you
I
guys.
don't know about you, Lindsay, but sometimes the sleep for me would be so bad that if I had something important to do the next day, I was just like, oh my goodness, how am I going to get through this?
How am I going to get this done?
Yeah.
Yeah. And then you throw in a night sweat in there where like you're drenched.
Yes.
Which is, that was fun.
Yeah. Yeah. Yeah.
That was awesome. That was something unreal.
So covered a lot there. So what is the, and I know you can't pinpoint an exact age. What is a average age that a woman could, expect to start to realize symptoms for this? I know it can be a very broad range.
It's a very broad range. So the average age in the United States for women to go through menopause is about like 51 and a half, 52. That's average age. The average, so then you're kind of considering up to 10 years prior to that.
Yeah, because that's just that day in time where you don't have a period for one whole year.
Normal menopause can happen as early as 45, and we don't really blink an eye at that. So you figure that puts her 35 when she could potentially begin experiencing some symptoms. Our testosterone in women will start to decline late 20s, early 30s, but for a long time, it doesn't get to a level that it's like critical mass.
Yeah. Well, and honestly, and probably still at that time, a lot of, think of where a lot of people are in their life. And now everybody's different, but a lot of times, like your kids aren't growing up playing sports yet, and so you may not notice the effects of it. But then, when your kids start being in activities and you get farther along, and then you are running more, and then you probably start to notice it.
Yeah. So that's it. So it's a very broad range, but late 30s, early 40s is kind of the earlier standpoint. Definitely by late 40s, I'm having 46, 47, 48. Those ladies, we are really having some interesting conversations.
For me, I felt pretty good until I got about 47, 48. And then I feel like it kind of hit me. Either I wasn't self-aware enough, but that's when I started really noticing late 40s.
Late 40s.
Yeah.
And the other, the caveat to that too is that you don't have to be postmenopausal for estrogen therapy. You don't have to be postmenopausal for progesterone therapy. So you still have all of those tools in the toolbox. It's just the prevalent hormone at that time that seems to be the most problematic is often the direction we'll start.
The BeFit Blueprint is sponsored by Precision Metalworks. Attention, makers, creators, and doers. When precision is key, you need a partner you can trust. That's where Precision Metalworks comes in. With decades of experience crafting high-quality custom metal components, they bring your vision to life with precision engineering, unbeatable craftsmanship, and a commitment to excellence. Whether you're in aerospace, automotive, or looking for that one-of-a-kind custom project, they've got the tools and experience to get it done the right way the first time. Don't settle for less. Choose Precision Metalworks, where innovation meets precision. Visit precision-metal-works.com today, and let's build something amazing together.
Awesome. Okay. Actually, Cailie, I do, before we move on, I do want to hear a little bit about your experience, because you and me have talked a little bit, your experience of how you started on your hormone replacement therapy and the original route that you were put on before you switched lanes.
So for me, the first thing I actually noticed was my hair thinning. That was like the very first thing I noticed. And then I started noticing like low energy, really low energy, and a little bit of hot flashes from time to time, not terrible. But I had really bad anxiety all of a sudden, something I'd never experienced in my life, and terrible brain fog. And so I actually talked to some other women I respect in the health space and did a lot of research. I probably researched for almost a year before I decided to try hormone replacement therapy. And then I had a provider recommended to me, and she discovered that I also had, that was one of my questions for you, Lindsay, is a subclinical hypothyroidism. And so she treated me for that, and then I started with progesterone, and right away both of those things helped. But now I had a hard time tolerating the thyroid medication that she recommended, so I went off that for a while. The progesterone helped, but then really, really started struggling with the thyroid. And so since then, she put me on a different medication, which seems to be working really well. And then about 2 months ago, I started estrogen.
Yeah.
And so estrogen and progesterone, no testosterone yet. But then the
may not
thyroid,
need it.
but then the thyroid medication, and I feel like a different person. I feel like,
do you feel like a different person, or do you feel like yourself?
Okay,
again?
no, I was just going to say, I feel like I did 10 years ago.
Yeah.
That's a good feeling.
So it is. I didn't realize how bad it was until I felt better.
Yeah.
Yep.
So that's just been my personal experience. And I think one thing that listeners need to be aware of that I wasn't aware of was how much perimenopause symptoms can overlap thyroid symptoms. So it's hard to know sometimes what is causing the problem, whether it's a hypothyroidism or perimenopause or both.
Yeah.
And so for me, that was like something I really struggled with kind of hammering out.
Okay. All right. Before we get to some questions, because I know this part won't take nearly as long, I do want to cover on the men's side of some hormone replacement therapy, specifically testosterone.
Yep.
I will let you tell us all about what you know about that.
Okay, so it's not so much hormone replacement therapy. We just call it TRT. Testosterone replacement therapy. Yeah. I am seeing younger and younger and younger men with lower and lower and lower testosterones.
Which that's a whole different story. We could dive into.
That's another podcast.
Yeah, that's a different podcast. But there's some very interesting research on that.
Very interesting, and why that is happening. But, men that have low testosterone, it's a lot of different symptoms. Poor sleep, lots of fatigue, muscle aches and pains, joint aches, things that weren't there before, brain fog, irritability, and then sexual side effects, decreased libido, but the energy, sleep, and the libido are probably the biggest ones. When I do TRT in men, I am not trying to build Arnold Schwarzenegger.
Yeah.
I am looking for very physiologic doses of your testosterone.
Therapeutic dose gets you back into...
Go back to where you should be, not where you want to be.
And so I have a question with that. So the range for testosterone is very wide.
It's very wide.
Was it 200 to like 1100 or something like that?
Something like that, yeah.
So, and this is why, and I haven't done this myself, but like if you are someone, like I would recommend getting tested somewhat frequently. Maybe once a year or something, because while you could still be in the normal range, it may not be your normal, correct? Like if someone is at like 400, but they are normally in the past have been like 800, they are going to feel all of those symptoms, correct?
Right. So again, the labs are a tool, and so you can do that, and you can trend it, and that's a very reasonable way to do it. Or if you just start to notice that those symptoms have come on.
Yeah.
The other thing that what I have to deal with in primary care is that we have to keep the insurance company happy. And so they dictate a lot of the options. But most men under 300 is going to feel terrible. They're going to feel bad. Most men are going to feel better somewhere between 700 and 1100. And so that is a range where I do kind of shoot for a number to kind of see if we can't get you where you want to be. And there's lots of different ways to do all of these things. There's different routes to do all of this stuff, but it can make a huge impact.
Okay. And then is there any, I'm sure there's probably not a ton, but is there any pushback with that? Like, how there is with women or anything?
Mainly just in whether or not you can get coverage for it or different things. The other thing you have to keep in mind with TRT, though, is if you are a man who is not done having children, do not do TRT yet, unless you want to bank your sperm.
Yeah.
Because it will definitely decrease your sperm production, and it may or may not come back. Usually it does.
Yeah.
But I am not going to run the risk of doing that to a 20-something, 30-something.
Yeah, again, it's risk versus reward there. Because I have heard of a few, just people talk like a very low therapeutic dose that they were still able to have children on that.
Sure.
So, but again, risk versus reward.
It's not that you can't,
but
it's the risk of, do I really want to run the risk of decreasing this man's fertility?
Yeah, especially if they're not done having children.
Yeah.
Yeah. And, average age on that, I mean, what would you say the average age for men that, obviously it's getting lower and lower, but at this point in time,
40s
to the best
50s.
40s and 50s.
Yeah, it's where I start to see it. And then we do have a lot of new research on this. There was a study called the Traverse study that came out that did kind of finally define that no, testosterone therapy is not going to increase your risk of prostate cancer. And it's risk versus benefit conversation regarding the cardiovascular help, because you have to look at all the benefits you get from hormone therapy, regardless, in addition to the risks.
Yeah.
And that is a lot that I do with the women's side of things too. So.
And, they'll get a lot of the same, relief from the symptoms you talked about, the same benefits of the women as well. I mean, you'll have energy, libido, all of those things.
All those things. Yes, very
Perfect. All right. Well, we do have some questions from members that sent in. So this one, Cailie, you kind of touched on this already. Explain the relationship between hypothyroidism and perimenopause.
That was my question.
Okay. Both seem to happen at the same time. Okay. So once a woman is postmenopausal, how long should she stay on HRT? A member asked.
Technically, as long as she wants to.
Okay.
There is no data now that supports that you have to come up off of testosterone, estrogen, progesterone therapy.
So if they do decide to come off, though, do the symptoms come back that they were feeling before?
Maybe, maybe not.
Okay.
I've heard some that have.
Yeah.
I've actually had personal experience with people that went off and were like,
Yeah. And so then we go right back on.
Yeah.
Okay.
Yeah.
For
the most part, I think it is most of the time you will still have some recurrence of symptoms, because it's like you're kind of starting all over again. You had all the estrogen, less than what you used to, but you had estrogen and now you don't.
Okay, I just didn't know if there was like a leveling off of those feelings after you got through.
I have some 80 and 70-year-old ladies in my practice that still have hot flashes.
Wow. Okay. All right. Okay. Next question. Does the physician managing HRT prescription change the dosage? If so, how often?
There is no set, like, I have to do this. But the woman you are today is different than the woman you are in 6 months or 10 years or 20 years. And so the dose may change based on your needs, but not based on any sort of like specific thing.
Yeah.
Now, I usually start women off on less medicine more medicine.
Yeah.
And so we might increase the dose till we find what works for you, because it's all about figuring out what you need, not what the masses need.
Yeah. And that just, I assume that probably goes by how they're feeling. Just like the on how you figured out what they need in the first place. You just continue going off that.
And sometimes we check some labs because it's nice to have that tool to decide. But if you came to me and said, I feel so much better, I feel like myself, and I checked the lab and the lab still wasn't great, I don't really care so much about the lab.
Yeah.
If you come in and say, I feel terrible, I'm not where I'm supposed to be, we check the lab goes along with that. Well, we can work with this. Yeah.
Okay. Because that was kind of, some of these questions are, how often should a woman who is perimenopause have their labs drawn for correct HRT dosing? Again, it kind of goes back to.
Goes on how she feels.
The labs are a tool, not necessarily the end all be all.
Correct.
The BeFit Blueprint is brought to you by the Cailie House, where furniture shopping is as comfortable as the pieces you'll find there. With the best selection of furniture and mattresses, they make it easy to love coming home after a long day of crushing your goals. Want to elevate your living space as much as your fitness goals? Head to Riverside and Frederick for a personalized shopping experience you'll actually enjoy at the Cailie House in St. Joseph.
Okay. Now this one I have no experience with, so you may or may not. If a woman is positive for the MTHFR homozygous gene, is HRT a safe option for her?
So there is a lot of stuff on social media these days with the MTHFR. That is not even a gene mutation, it is a gene variant, meaning that about slightly less than 50% of Americans, I think, have that gene mutation or gene variant. And so the short answer is no. That shouldn't really affect your ability to do estradiol, because when you were a menstruating woman, you had estradiol and oh my gosh, you did just fine. So I don't really think it's all that relevant. Now there's ongoing research to it, but right now this is just the new fear factor to sell you the $80 supplement when a $5 supplement would get it done. But that may be a little personal.
Kind of nuanced. Yeah.
Getting in the weeds there.
Getting in the weeds,
yeah.
Okay. Let's see. How long post-menopause does it benefit women to stay on hormone replacement therapy? Talked about that. Basically, it doesn't ever stop helping you out.
Right. So when I talk to women and men, for that matter, about hormone therapy, we talk about two sets of goals. I talk about the goals for now and the goals for tomorrow. So the goals for now are to sleep better, have more energy, be able to do all the things, balance all the things. And the goals for tomorrow are, my grandmother's died from dementia and osteoporosis. I do not want that to happen. And so my hormone therapy at that time would be something that would help me prevent those kinds of things.
Okay.
My heart disease, we need to be more afraid of heart disease, and we're not.
Yeah.
1 in 5 women, I think, dies of heart disease. That's the number 1 killer for women in our country. Being on hormone therapy decreases that risk as long as you were started on it properly and it was done the correct way.
Well, I actually have a question on that because my lipid profile went crazy.
Before or after you started on?
Before.
Yes.
So my lipid profile, and I shared with Cody a little bit my A1C.
Yeah.
Well, it was not in the pre-diabetic range, but I was like, what? Like,
excuse me? Yes.
Yeah.
So with that fluctuation to estrogen, our metabolism shifts, and that's part of how we end up with the what they refer to as the meno belly, which is a horrible name. But you will notice definitely that your lipid profiles can really start to change, your triglycerides and your insulin resistance, and all of that has to do with estrogen.
Yeah. What about the thyroid as well? So I kind of touched on that, but what are your thoughts on why that might happen?
Again, there's just every tissue in our body has estrogen receptors. And so I do think there is some correlation. I don't think they have it like nailed out what it is. I think we have more problems with the subclinical hypothyroidism than we realize, because it's, as the clinician or the physician, it's very difficult to test for that and not send you a big bill.
Well, I had my practitioner, 2 practitioners. I have like a family practice doctor, and then I have a hormone specialist doctor I see. So my family practice doctor said, your thyroid's fine. Your thyroid's fine. And I was like, I feel like garbage.
Yes.
And so
there's additional testing that they do.
And she did. And she's like,
T3
nope, your
and the
TSH.
T4.
She said your TSH mine was off the chart high.
Yeah.
And I noticed, when she treated it, I felt so much better.
Yeah. So there's, just because the labs are quote unquote normal doesn't necessarily mean they're optimal. And there's a big difference that, just because I can deadlift 100 pounds doesn't mean that I can't figure out how to deadlift 200 pounds.
Yeah. Right.
Did when you saw your family med doctor, did they try to do any other like routes to, fix the issues at hand? No, it was just
they said it was in normal range.
Okay.
Yeah. Well, they would have said it was normal range, and then they said, well, now for your anxiety, here is your SSRI.
Correct.
Yeah.
Correct.
So we try to treat perimenopausal and menopausal symptoms with other medications when we can oftentimes treat the majority of the symptoms with one thing.
I'm certain that I could have, if I hadn't maybe tried HRT, I could have been on an SSRI, potentially a statin, and potentially metformin.
And a sleep medicine.
Yes. So, so if you're scared of HRT, but not scared of all these other prescriptions and the side effects. I mean, that's kind of where you got to kind of weigh the pros and cons. But I honestly feel like that's kind of the route I would have gone down had I not done my own research.
Yeah. And that's kind of the whole point of why we're doing this, because it's not talked about. And so if, people, women go to the doctor or go wherever and, go with the same symptoms you got, might be told the same thing. And if they don't know better, haven't done any research, they're just like, okay, I'll do exactly that, and it can help, but it may not be the easiest and quote unquote most optimal solution for them. Yeah.
So Lindsay, do you think that, I haven't had my blood work done, do you suspect that with thyroid treatment and estradiol, that lipid profile and A1C would change? Okay. Yeah, I'll be anxious to see that. Yeah.
Yeah. I think the other important thing to point out here, and I try very hard, like there are all sorts, everybody practices as a physician differently, and depending upon what you're interested in kind of guides what you are, down in the weeds. Every day I'm reading something about HRT and that's something that has become a passion project of mine. Whereas there's going to be a number of providers even in town that are going to tell everybody and their friends that I'm a heretic.
Yeah.
and so trying to find a provider that fits your goals or your needs, knowing that it's not because that's a bad doctor that they don't want to. It's just that is not their wheelhouse.
Yeah.
And so maybe finding somebody
else.
They
can't be an expert in everything.
No, and
I
there's so
that.
much stuff to do. But finding someone that has gone and done some extra education in those things can be helpful.
Yeah, definitely.
And going back, so I do have a question. So when you were talking about heart disease, decreasing the risk, I got a question about like chicken or the egg. Which came first? Is it because the hormones decrease the risk, or would it be because the hormones make you feel better and you're able to do all of the things that you weren't doing before? You're more active, you're getting more sleep, you're exercising, or do we know?
Why does it have to be one or the other?
I'm just curious.
Yeah, So when you have a steady state of hormones, you are less inflamed. And inflammation is also a new, we talk about all this inflammation. So being estrogen deficient is an inflammatory state. And in an inflammatory state, you are better at building plaque or putting plaque down on that endothelium. So it definitely helps. It is a tool, just like the lifestyle stuff is a tool. But when you do all the things and you're still struggling, this can be the missing piece.
Yeah.
And so I usually really talk to women about we have to do all the things first. Because if you don't have to take additional supplements, medications, whatever, okay, I'm not in the business of putting people on medicine. As strange as that sounds to come from a doctor. But I want you to do all the things. But if you struggle to do all the things because you are so tired or because your sleep is terrible, again, it's a tool that can be helpful.
Yeah. No, and then that's what I'm saying. Like, I think it can help. Like,
it helps you do the things.
Exactly.
Yes,
and
it
I
does.
think doing the things is probably the most important thing, no matter how you do them, how many, like, I don't want to say clinicians, but how many, doctors, and not a specific number, and I'm sure it's an ever growing number, but how widely accepted is hormone therapy now?
It is improving, but it is still well below average. In fact, one of my nurses went to her gynecologist, who I swear is a decade younger than me. And she asked her about HRT because I had been telling her for a while, like, hey, we could maybe talk about this. And that doctor told her, oh, I don't prescribe those. This is a gynecologist. I don't prescribe those.
Yeah,
those
they
cause
just
cancer.
don't have much training.
Because we get zero training. There's no training. And in fact, my hormone therapy or my menopause education in med school was maybe
Next to
one
none.
lecture.
Wow.
Maybe one. Maybe. And I don't really remember it that well.
Wow.
Like I said, I did basically for a year researched.
Now, there are some really great resources that are available both for clinicians or physicians as well as women that are not in healthcare now. And there are some really great educated women that are doing really great education online and others. And I have used those resources for women a lot for education, talking about everything from how to strength train, because that's really important for my perimenopause, menopausal ladies, how to eat better, and how to avoid those pitfalls.
Do you see down the road, do you see that changing, like through like med school and stuff? Do you see the curriculum changing?
So. I think the tide is shifting because millennials are saying, no, we're not. I'm not doing that. I'm not doing that.
It's having a moment.
It's having a moment.
Yeah.
And so I think that there will be more research. I think that there will be more education. I think that as our women educate themselves from not from TikTok.
Yes. Got a bunch of TikTok doctors out there.
From really reasonable and educated sources. I think that the tide is shifting, and I hope to be on the the right side of history with this. But I know that the women in my practice and the men in my practice too, they come back and they say, wow, thank you for doing this.
Yeah.
No one ever thanks me for their statin. They don't thank me for their blood pressure medicine. But they come back just, wow, I feel like myself again. And that reward is very helpful.
That's huge.
It's huge. It's huge because that's what we should strive for. We should strive to feel good.
Normal.
That should be what it's all about.
Yeah.
All right. Well, Lindsay, Cailie, thank you for joining us today on the BeFit Blueprint. Remember, leave a review, all right, on Spotify and Apple Podcast. And you are entered for a chance to get a free BeFit Blueprint shirt. We'll reach out to the winners from last week. We will see you in November for episode 11. Thanks for joining us.
Thanks so much for listening to the BeFit Blueprint podcast. If you would, please subscribe, like, comment, and share on Spotify, Apple, or YouTube, or whichever platform it is that you listen to the BeFit Blueprint podcast.